Functional neurosurgery scares people in the exam, not because it's hard, but because it's undertaught. In this series, we fix that. Not just the right answer, but the idea behind it, so you can reason any question in the room. Part 1. Abnormal movements. It feels intimidating for 3 reasons. It isn't part of basic training, most units don't do much of it, and you rarely see it. But here's the good news. Examiner expectations are low, and the basics are genuinely all you need. Let's build those basics. Functional splits into 3 exam topics: movement disorders, pain surgery, and epilepsy. Today is movement. And movement in this exam means, above all, Parkinson's disease and deep brain stimulation. It's tested 2 ways: multiple choice questions on indications, targets, and stimulation side effects, and a viva, where you examine a case. This video drills the reasoning through 4 ideas. First idea: know what deep brain stimulation is good at. Parkinson's has 4 cardinal features. Bradykinesia is mandatory for the diagnosis. But for surgery, the single fact to burn in is this: tremor responds best to deep brain stimulation. Gait freezing, speech, and cognition respond poorly. And cognition can even be worsened by stimulation. Almost any "what improves most" question is testing this one line. Tremor is the symptom that responds best to deep brain stimulation. Balance, speech, and postural instability all respond poorly, which is exactly why they're the distractors. Second idea: target selection. The classic line is first choice subthalamic nucleus, second choice globus pallidus internus. Memorize it, but understand the exceptions, because that's where the marks are. If dyskinesia dominates, the globus pallidus internus is preferred. It smooths dyskinesia directly. If tremor dominates, the ventral intermediate nucleus of the thalamus is the tremor target. Same disease, 3 targets. The question tells you which by naming the dominant problem. The subthalamic nucleus, the default first choice. The globus pallidus internus is second. The anterior limb of the internal capsule is an obsessive-compulsive disorder target, not a Parkinson's one. The globus pallidus internus. The exception to subthalamic nucleus first. When dyskinesia leads, the globus pallidus internus controls it best. The ventral intermediate nucleus of the thalamus, the thalamic tremor target. Zona interta is a tempting modern distractor, but the ventral intermediate nucleus is the exam answer. Third idea: patient selection, and here the exam lives in the exclusions. Include disease over 5 years, a meaningful levodopa response, disabling fluctuations, or refractory tremor. Exclude dementia, untreated depression or psychosis, and atypical Parkinsonism, like progressive supranuclear palsy and multiple system atrophy. The trap question gives you a perfect surgical candidate and slips 1 red flag into the options. Spot the red flag. And 1 linked fact: the levodopa challenge isn't about severity. It predicts the response to deep brain stimulation. Stimulation of the subthalamic nucleus roughly reproduces the patient's best medication on state. So a good levodopa response predicts a good stimulation response. Ongoing depression. A, B, and C are textbook good candidates. The untreated psychiatric disease is the contraindication, a classic exam pattern. Progressive supranuclear palsy, an atypical Parkinson plus syndrome. Atypical Parkinsonism doesn't respond to deep brain stimulation and is a contraindication. The likelihood of a response to deep brain stimulation, not severity. If levodopa helps, stimulation is likely to help. Fourth idea, and the highest yield anatomy, side effects during macrostimulation. Think direction at the subthalamic nucleus. Medial spread hits the third cranial nerve and red nucleus, giving diplopia. Lateral spread hits the internal capsule, giving contralateral twitching and dysarthria at the globus pallidus internus. Ventral spread hits the optic tract, giving phosphenes, flashes of light. Posteromedial spread hits the capsule, giving muscle contraction. The exam rule, the side effect tells you where the electrode is, and you correct by moving away from the structure you're hitting. Lateral. The motor fibers run in the internal capsule just lateral to the subthalamic nucleus. Twitching means you're too lateral. Move medially away from the capsule. Twitching is lateral, so the correction is medial. Reducing voltage just shrinks your therapeutic window. It doesn't fix the position. The red nucleus, diplopia, is the medial side effect. From spread toward the third cranial nerve and red nucleus. It's the mirror image of twitching. The optic tract, it sits ventral to the globus pallidus internus. So ventral spread produces flashes of light, phosphenes. One bonus fact examiners love: the dopamine transporter scan. It separates Parkinson's from essential tremor and drug-induced tremor. Reduced uptake, worst in the posterior putamen. But it does not distinguish Parkinson's from atypical Parkinsonism. Same limitation as deep brain stimulation itself. Atypical is the blind spot. 4 ideas carry the whole Parkinson's question set. Tremor responds best. The subthalamic nucleus first, the globus pallidus internus for dyskinesia, the ventral intermediate nucleus for tremor. Selection is 1 on the exclusions. And with stimulation, the side effect tells you the direction. Learn the ideas and you don't memorize answers. You derive them. Next in the series, the Parkinson's Viva, how to examine a case and pass the station. If this made functional feel smaller, subscribe, and I'll see you in part 2.